Okay, so welcome to the 10th session of teaching for the MBBS students. So on popular request, I think we have to start on labor. So one of the, probably I'll be doing a few classes on labor. So this is the first of those classes, right? So now today what we are going to concentrate on is basically the only part where the patient is in the labor room, right? And then how we manage a normal labor. Okay. The next section, for some reason I have, okay. So the next session, will probably concentrate on CTG, right? And then I will go to different kinds of problems that we'll encounter in labor, right? So I will do a different session on that. One moment. Right, sorry. So first today we are going to concentrate on labor itself, the general principles of management. There will be another session on CTG, or not really CTG, we'll call it fetal monitoring in labor. Right, next, probably we'll do a session on the problems that we encounter in labor, right? Specific problems like secondary errors, delayed second stage, first stage, so all those we'll do. So our abnormal labor, and then the fourth session probably will be on labor in specific problems like managing a patient with diabetes, managing a labor with a patient with hypertension, psychiatric problems, hypothyroidism. So we'll go for that in different, and then probably we'll have to also do instrumental deliveries in another one, and so on and so on. So I think labor will consist of quite a few. Plus, then there are emergencies that can occur in labor. So those will be separate topics. So basically, there'll be lots and lots of topics in labor. So we'll get to that slowly, right? So now, today's session is on what happens in the labor ward. So now, first of all, children as house officers, one of the main things that we do, or that you all need to do, is to take a decision as to when to send the patient to the labor room. Okay, and that you need to do very properly as house officers when you come in. So the decision will be with you all as house officers, and you are the ones who will decide, okay, this patient needs to go into the labor room. Now remember, there are two sets of patients that you will meet. Right? So the one set of patients are the patients who are in labor, or that you think they may be in labor, and you need to diagnose their labor and find out exactly where they are, and then decide on whether to send them to labor room or not. That is the first level. The second type of patients you will meet are the ones that are undergoing routine inductions, right? Where a decision has been made to deliver the patient. So there may be certain things that have been done beforehand, like putting in a prostaglandin or a Foley catheter to ripen the cervix or to send them off to labor. And then routinely, these patients will be sent to the labor room in the morning for a routine induction as practiced in your unit. So depends on the unit. It might consist of just starting oxytocin. It might consist of artificial rupture of the membranes. And then after checking the color of the amniotic fluid and its volume, if everything is all right, then to start off the labor with oxytocin, right? Or there may be, so these are the routine inductions that you will need to do as house officers who are in charge of the labor rooms. That will be usually in the morning. I'm not going to talk about, so that is one portion. The second portion are the women who are waiting for the spontaneous onset of labor in the ward, and the women who will come in to our wards, right, with or in labor, with pain, so they might be in labor, right? So these are the types of patients that you are going to see and decide. So initially, there is the, in the ward, there will be the routine assessment. Now, for that, what you have to understand is, the patient will come to you with complaints of a few, it might be with a few complaints. Number one is, they'll be complaining of pain, right? So labor pain is usually what? They get a contraction, which is painful, right? Then there's complete cessation of pain. And again, there is a contraction, right? So these contractions might last up to about 1 minute, right? Or it may be less strong contractions. And therefore, you will need to ask them, okay, how often are you contracting? That is, what is the time between the contractions? Is it, so normally we will take it in 10 minutes. So is it 2 to 3 times in 10 minutes? Is it 4 times, 5 times? So that is the way you find out about the frequency of contractions. That is number one, right? The second thing is, are these contractions painful? So usually there are contractions that are not painful, or maybe very slightly painful, which are called Braxton Hicks. Braxton Hicks are contractions that the woman feels the uterus tightens up, and those are actually practice contractions of the uterus trying to go into labor in the future. Okay, so then those are the contractions, right? And those contractions can be felt, and if you put your hand on the abdomen, you can feel the contractions with the uterus tightening up and lifting up, and it will touch your hand, right? So that is the uterine contractions which can be felt. So normally in patients in labor, these contractions are painful. What is the reason? Because the cervix is connected to the uterine muscle in such a way, when the cervix is closed, when there are contractions of the uterus, what happens is the cervix starts to shorten, right? These contractions pull the cervix in such a way that the cervix shortens and dilates, shortens, dilates. So what happens? Two processes happen at the same time. One is the shortening of the cervix, which we call what? The shortening of the cervix is one, and the other is the dilatation of the cervix, right? Shortening of the cervix is called effacement, right? While dilatation is called dilatation, right? So painful uterine contractions means those are labor contractions, and these contractions shorten and dilate the cervix. So these are actually the labor contractions. Now, the next thing which you need to ask when a patient comes, is there a fluid or is there a discharge vaginally which they have experienced? So if the membranes are ruptured, they will experience a gush of a watery sort of liquid, right? Which will normally run down the legs. So small amount is very, very rare for a ruptured membrane. Usually there's a lot of fluid that goes down their legs, right? And it can be of any color. Usually it will be not transparent, but whitish transparent, because there will be whitish fat tissue there. This is due to the covering of the baby, and there is a specific fattish material around the baby, and that goes into the amniotic fluid, because that helps the baby when it covering the baby. It helps the baby not to be hypothermic, and therefore, but usually when it comes out also, it protects the baby from being hypothermic. So we don't wipe it off immediately. So that will be floating around in the fluid. So there'll be a whitish sort of material, but normally it is clear. However, amniotic fluid can have meconium in it. Amniotic fluid can have blood in it, right? Very preterm amniotic fluid will be quite sort of transparent, right? Or there may be meconium stain. So if it is very old meconium, it can look blackish, right? If it is very fresh meconium, or recently the baby has passed on, then it will be greenish, right? Remember, the understanding of thick meconium or thin meconium is simply based on the fact, right, that the same amount of feces or meconium that the baby passes is dissolved, right, in an amount of amniotic fluid. So if the amniotic fluid volume is low, the same amount dissolves in that, you get a thick meconium. You understand? So when do we have a small amount of amniotic fluid? Usually we call it oligohydramnios, and usually it is when the placenta is not functioning properly. So therefore the baby is not getting enough blood to the kidneys, and therefore the baby is not producing enough urine, and therefore the amniotic fluid volume goes down. And that usually is when there's a chronic problem with the placenta and the blood supply to the baby. So remember, the most of the amniotic fluid volume or amniotic fluid is dependent on the baby's urination. So baby urinates, and then the amniotic fluid is normal. So if there's a good supply of blood to the kidneys, the amniotic fluid volume is good. So if there's a good amount of amniotic fluid and the baby passes meconium, that will be dissolved in a lot of fluid, and we basically get what we call thin meconium. And if the amount of amniotic fluid is so small, and the same amount of meconium, if it dissolves in that, you get thick meconium, right? So if the woman comes and tells you that she's passing a liquid, and then you will need to check whether it is coming through the cervix by doing a speculum examination to see whether it contains blood, or whether it contains meconium, or whether it contains the normal sort of consistency, which is transparent with whitish material, right? So these are the things that you need to see. So that is the second thing. So we need to ask about the contractions, whether they are painful and how often they come and how long they last. Number two, we need to ask whether she is discharging from something from the vagina. So if it is fluid, we need to ask the questions there. Number three, which you need to ask is to see whether she has discharged anything like a mucus plug. What does that mean? See, the cervix, when it opens up, there is mucus there, all right? And when it starts to contract, what happens is the cervix opens or dilates and shortens. So that mucus plug comes out. But when the cervix dilates and shortens, the small blood vessels also start to break there, right? So these blood vessels blood will mix with the mucus, and it becomes reddish in color. That is what we say as show, right? So we need to ask, okay, are you discharging something which is slightly blood stained and thick. So that is what we call shock. So that might signal the onset of labor, right? So taking all this into consideration, remember, you as an internal house officer need to diagnose whether the patient is in labor. So remember now, labor consists of stages. We have what we call the first stage, the second stage, and the third stage. Okay. The first stage is sort of divided into a latent phase and an active phase of labor. So the latent phase is what we call from zero dilatation, that is from no dilatation, up to 4 centimeters dilatation is the latent phase. So during this phase, in a woman who goes into spontaneous labor, you can keep this woman in the ward, right? We don't need to put her in the labor ward. So in other countries, they might keep her at home, right? They might not want her to come in initially, right? Or they can be kept in not exactly a labor suite, but outside in an observation room where the patient is kept until 4 centimeters dilatation. In our wards, if a woman does come with contractions or pain, right, it is your duty to diagnose and understand whether this woman is in the active phase of the first stage or whether this woman is in the latent phase of the first stage of labor. Remember, if she is having a ruptured membranes without any contractions, please do not do a vaginal examination. What is the reason? Usually with ruptured membranes, we can wait normally up to 24 hours for the woman to go into labor. Right? Or from the time of ruptured membranes, if there are no other problems from our clinical examination, like signs of infection, signs of fetal compromise, right? She's not bleeding, if the fetal assessment is normal, right? Then there's no reason for us to put her in the labor room and start something, because probably she will go into labor. So we don't, but do not do vaginal examinations, because that will introduce infection into the amniotic cavity, and that can cause chorioamnitis and problems to the fetus and the mother. So the best way to go about it, if she has no signs of active labor, please do a speculum examination. You can get the same amount of information as you do for a vaginal examination, or actually more. And what are the things that we get? We can check, right? Right. So we can with the speculum examination, we can check the cervical dilatation. We can check the fluid that is coming through the cervix. We can look at the color. We can check whether there is blood, whether there is meconium, whether there is fresh meconium, whether that is greenish, whether it is old meconium that is blackish, right? Whether it is thick, which means small amount of fluid, the same amount of meconium mixed in it, or whether it is thin, which is lot of fluid, which is a good thing, and the same amount of meconium mixed in that will give us what we call thin meconium. So all those we can judge by doing a speculum examination. And what does that give us? It gives us the freedom, right, if everything is all right, to wait for 24 hours from the rupture of the membranes, right, for her to go into spontaneous labor. Why? If she goes into spontaneous labor, there are some important things that we have to understand. Number one is the chances of her delivering vagina is very good, because the whole body is prepared for that. The oxytocin receptors in the uterine muscle is well primed, and the number of them in 1 square millimeter increases as soon as labor starts. So the same amount of oxytocin can stimulate the uterus move. So that builds up within the first 24 hours or so after the rupture of membranes. The second thing is, it has been found out that the labor is less painful, right, if she goes into spontaneous labor than us trying to give her contractions with using oxytocin or any other medication, which may be uncoordinated due to the fact that it is not physiological, and therefore the labor is more dystocic. That means there may be problems in labor, there can be more fetal distress, and it can be more painful. And therefore, since the amount of infections do not go up within the first 24 hours, right? And if there's no problem, we can really keep them without trying to intervene at an early stage. However, if a house officer does a vaginal examination, then of course, probably we might be forced to put the patient in the labor room and start her off, because that vaginal examination may have introduced infection, which is not good for the baby or the mother. Is that clear? So then what happens is, now, how do we diagnose labor? Yes, so if it is a ruptured membrane, and if she has no contraction and doesn't seem to be in labor, please do a sterile speculum examination. If she has no ruptured membranes, then of course you can do a vaginal examination if you think it is swing. And if you are really not sure, please do 2 vaginal examinations 4 hours apart. Or if the pain is more, you can do it even in maybe 2 hours. So if you are really not sure whether this woman is in labor and she's having mild pains, so you are really not sure, as also you don't need to just say you do a vaginal examination for, especially for a multiparous woman, she may be having a 3 to 4 centimeter dilated cervix, right? And she may not be in labor, right? She may be in that stage for a long time, right? And maybe for the last 2-3 weeks, she has been like that, but actually she's not in labor because she has a naturally dilated cervix. So you do a vaginal exam when she comes in with slight complaint or something, you think she's in labor and you send her off to the labor room, right? So which is not good, because actually you have misdiagnosed the fact that she may be in the latent phase actually. So what you do is, if you are not sure, children, as internal health officers who are managing this, please keep the patient in the ward if there are no problems. Just repeat your vaginal examination 2 to 3 hours, maybe 4 hours later. And of course, if there's a progress, then you diagnose that she is in labor, okay? And then only you send her to the labor ward, right? Is that clear? So then going from there, there are some questions. What is the most appropriate phrase to describe the progression of the first stage of labor till first? So it's actually the latent phase of the first stage of labor. Cervical dilatation, I don't know what that means. Regular, is somebody answering the question? I have no idea. Regular different contraction, descent of the head station, effacement. Okay. What is the active phase? Active phase basically in a nutshell is active phase of this first stage. So first stage starts from 0 dilatation to full dilatation of the cervix. Okay. Active phase of the first stage of labor is basically from 0 to 4 centimeters, and the latent phase, and the active phase is from 4 centimeters to full dilatation. Right. So that is, so what does that mean? Basically, that is our cutoff mark where we ask the patients or we send the patients to the labor room, right? Now, in different women, right, this latent phase can change. It may be 2 hours, 3 hours, 4 hours, 5 hours, right? So it might change. So the woman might have a bit of contraction, a bit of pain, then no pain. So that can slowly sort of progress until she goes into active phase of the first stage, right? So what do we do in the latent phase? Now, if we diagnose this woman, and if you are really not sure whether it's an active phase, just do a repeat wean in the 1 or 2 hours, or until she complains of labor or something happens like she ruptures her membranes. Okay. So what can we do? We can give analgesia or we can give pain relief. So that can be usually not narcotics, but you can give paracetamol along with codeine. In Sri Lanka, we have Panadol, right? Or you can give paracetamol and codeine separately, which is usually not practiced. So other countries will have their own different combinations of paracetamol and codeine, which can be used, right? Some countries might, or some might say, okay, give an anxiolytic or slow sedative, but usually that is not really required. So basically, we can ask the woman or manage the woman in the not in the labor room, but in an observational facility or in a ward where they wait for the onset of labor, whether until they go into the active phase of the first stage of labor. Is that clear? Right. So then from there, we put them into the labor room if they go into the active phase, right? So this is where the labor room management starts, or labor management starts, right? So what I want to teach you is, so these are the initial sort of understanding what it means, right? What I want to teach you is basically today about the principles of labor ward management, right? So remember, I taught you about the principles. I taught you about if you give something like pethidine or morphine, right? And that is one part of what? A larger principle. And the larger principle is always analgesia. Okay. If you want to prevent infection during labor, you might need to observe certain conditions of hygiene. So the bigger principle is prevention of infection, but there are a lot of things which we do under the same principle. Okay. Then you all understand. So today, what is very important as medical students, what you have to remember is, please remember the principles. Small details you can fill in later, right? But if you don't know or do not know the principle completely, then of course you will never get the smaller details at all. So learn the principles, and then as time goes on and you all get older, right, you will get the smaller print into your brains. Okay. Right. So let's start with the first principle. Now, the whole labor is divided into several principles which you need to understand, right? Some of these principles will be centered on the baby, and some of these principles will be centered on the mother, right? Or the woman who is in labor. So let's start with the woman, because most of the principles about the baby is about fetal monitoring, okay? And that is a different topic which you are going to talk about at a later stage, right? So that will include all sorts of types of fetal monitoring, including auscultation, PNAD, Dopplers, CTG, right? Ultrasound during labor. So, and fetal blood sampling, right? Scalp sampling, all those will come back later. So mainly today we are talking about the woman. The first thing is I'm going to talk only about a woman who has no pre-existing problems, because we will do another lesson actually on patients with diabetes, patients with hypertension, or the different problems that we can occur. So today we are just going to look at a normal labor. Okay. Principle number one, we'll start with nutrition. Once the patient is put in the labor, can she eat and drink? The answer is yes. Okay. If there is no big problem, right, and if there are no specific problems that she has, and if we are not contemplating on going for a emergency section, if everything is going on normally, yes, she can eat and drink, and she can't take like in Sri Lanka, you know, large rice and biryani and all that, but a light snack is absolutely preferable, and she can drink during labor. She can have a fluids. There's no problem, so that she can be, you know, having a. However, if you are thinking that it is a patient who is having problems, then of course it's probably not wise to give her something to eat or drink. So remember that, right? Number one. Number two, problem or principle. hydration, right? First is nutrition. So remember, isotonic solutions to drink would be better, right? The second thing is hydration. It's extremely important to keep the woman hydrated. How? Either she drinks, right? Or we need to give her intravenous fluids if we have stopped her from taking fluids by mouth, right? And what is the normal amount of fluid we give to keep the woman hydrated? Is about 100 ml per hour. Okay, so we need to give about 100 ml per hour to keep her well hydrated. And of course, you need to be on the lookout for other things that can show us that there is dehydration. What are these? The lips will be dry, right? The urine output will go down, right? And also there'll be ketone bodies. If we check the urine, there'll be ketone bodies in the urine, right? So we need to keep her well hydrated. Remember that, right? So that is hydration. Why is hydration important? Dehydration will cause suppression of uterine contractions, right? And it will cause dystocic labor. So it is extremely important for us to keep a well hydrated. And the other thing about hydration is, if she is dehydrated, there will be hemoconcentration. If there's hemoconcentration, she has a higher chance of having thromboembolism, right? So therefore, it's very, very, very important for her to be well hydrated during labor. So that, children, is the second principle. Easy because you have to understand what hydration means. Okay. The next principle that we need to speak about in labor, right, is analgesia. How do we make the labor less painful? The biggest problem, one of the biggest problems women encounter during these sessions is pain. And what do we offer for pain relief in these women, right? There is non-pharmacological methods and there are pharmacological methods, okay? Non-pharmacological, it has been found, right? If there's a labor companion who is known to the patient, right, the requirement for analgesia is less. However, in Sri Lanka, at the moment, in the government sector, we do not have separate cubicles with separate instruments, and separate one-to-one care is difficult, right? So if there's a separate room, everything needs to be in that room, right? Where her bed, her facilities for monitoring, CTG, facilities for infusion pumps, and there has to be a midwife or a nurse in attendance. So that's one-to-one care, right? We do not have that number of staff for us to do a 24-hour rotation in the labor ward. So therefore, unfortunately, we cannot do it. However, so therefore, we cannot keep the spouses in most of our labor rooms, right? So therefore, that's a problem. However, the need for analgesia becomes less if there's somebody known to them. And the second thing is massage, for example, rubbing of the back, right, by the spouse or any attendant, right? And that eases the pain a bit. The rest of the things that have been used as specific other things, you know, like aromatherapy, lightning, all these things, of course, is not absolutely recommended. And remember, children, if you look at the NICE guidelines, right, on intrapartum care, that will give you a lot of information which you need to read through for this specific thing, which gives us a lot of information. Right. Next is.
Sorry, I didn't quite catch that. Could you please repeat it?
Yeah. So it's my Siri. Okay. Then did I say Siri? I don't. Right. Okay. So the next is pharmacological, which we basically remember we have three methods to give analgesia. Number one, we have pharmacological agents, right, which are narcotics. Okay. Number two, we have gases which you use, right? And number 3, we have epidural analgesia. These are the 3 main categories that you require or that you need to know. Number 1, we use narcotics, right, which are very potent analgesics, right? And the commonest narcotic we use, or 2 commonest narcotics which we use, are pethidine and morphine. Morphine less frequently, but can be used. But pethidine appears to be less potent than morphine, but it is more manageable and with requires less monitoring than morphine itself. And pethidine can be given intramuscular, while morphine we have to give subcutaneously, right? So, therefore, usually we use pethidine in that. So the requirement for pethidine is dependent on the weight. It's normally 1 milligram per kilogram every 4 hours. So you can repeat the pethidine every 4 hours. And however, it does not give us an absolute pain relief as we would expect. And especially it is all right in the initial stages, but normally it is not adequate as time goes on, right? And she gets more and more stronger contractions. Pethidine normally will not be sufficient to give adequate pain relief, right? So we can give 1 milligram per kg every 4 hours, right? And that we can start initially when the painful contractions start. Okay. Then morphine we don't use because what are the problems with narcotics? Number 1, it can cause respiratory depression, and especially if it is inadvertently given intravenous, it can cause respiratory distress or respiratory arrest. It can cause drowsiness, and it can also, remember, can cause nausea. That is why we always combine narcotics with an antiemetic. So that can be chlorpheniramine, which is Phenergan, right? It can be domperidone, it can be metoclopramide, any antiemetic you can, whatever you have, can be combined together because it causes nausea. So it can cause drowsiness, it can cause nausea. I'm talking about the woman, it can cause drowsiness, nausea, feeling of dizziness. They may be less alert, right? Inadvertently, if it is given, it can cause respiratory arrest, it can cause respiratory depression. And in the baby, it can also cause respiratory depression if given within 2 hours of birth, right? So therefore, we have to remember that pethidine or narcotics may give us problems. And as time goes on, it might not be very, very effective. Normally, it can be used in doses because our females in Sri Lanka, most of them will be less than 75 kg. So we can, or around that. So we can give those starting doses from about 50 milligrams to 75 milligrams doses, which we can give, right? Rarely we can go up to 100 if necessary, if the weight is slightly more. Okay, so that is the narcotic that we use frequently. The second analgesic. So when we are talking about the analgesia, and we are talking about pharmacological, and we are talking about narcotics, right? And they have different routes. Morphine is subcut, so if you classify them by route, pethidine is usually intramuscular. However, pethidine can be used in smaller doses intravenous, but remember there has to be an anesthetic support, because for acute procedures we can use that will give more quicker response, but there is a chance that she might have respiratory arrest. So therefore we need to be prepared to be able to intubate and ventilate if she goes into a respiratory arrest, right? Got it? So that is pethidine. The next important thing that we use in our labor wards and of everyone is a gaseous mix, which is often called Entonox, which is the trade name, is a mixture of oxygen and nitrous oxide, 50%, 50%, right? And nitrous oxide is also called the laughing gas because it makes people cheerful apparently, okay? And therefore, this mixture can be used. Remember, it is an inhalation analgesia. The woman has to breathe it in, and she is given a specific nozzle or so where she breathes it in. And so we cannot hear you. Is that correct? This or this? All right, okay. So probably somebody is not hearing me. Sakuntala. Okay. Sakuntala, are you all right now? Jayatis sir, can you hear me? I have muted you also, just do this. This is you hear me, this is you don't hear me. Oh, Sakuntala. Okay, right. Right, okay. So yeah, I think only Sakuntala has the problem. So please sort it out. Something to do with the computer, I think. Okay. So where were we? Right. So the second thing, what we are talking about is, yeah, the principle of using this gas, nitrous oxide with 50-50, it comes in a cylinder, and or it can be a wall sort of piped nitrous oxide, right? And then the woman breathes it in. There's a nozzle which she puts into her mouth and breathes it in. The principle is get as much as internox you can, right? Between contractions, not during the contraction. So by the time the contraction comes, right? Remember that you have a contraction, complete cessation, no pain, contraction, complete cessation, contraction. Where there are no contraction, no pain, the woman breathes in the internox, right? So she gets a concentration in her body, in her blood, up, and when the contraction comes, the pain becomes less. So that is the way it must use. So women need to be trained and taught in the labor ward by the attending person as to how to use this gas. It gives quite a good analgesia. And once the contraction passes, the woman breathes it out. It goes out with the breath. So they extrude it, right? And then again for the next contraction, she needs to get the internox in. The problem is it sometimes makes them restless and sometimes make them breathless. There is breathlessness when you do that, right? So, and it makes them feel dizzy because what they are doing is between contractions, they are trying to get the gas in, and that causes dry mouth, that causes an unpleasant sort of feeling in the throat. It causes dizziness, right? So all these problems are because you are continuously inhaling the gas. So that, remember, those are the problems. And as labor goes on, sometimes it may be very much less effective than as with the pethidine. You can combine internox with narcotic analgesics. So that's not a problem as well. To get a better efficacy. Okay. The third analgesia, which is the most important one actually, is an epidural, right? An epidural is, earlier they were high dose epidurals, but now we call them the walking epidurals. What does that mean? It knocks off the pain, but the sensation of pulling is there. It knocks off the pain, right? And keeps the muscular functions intact or the motor functions intact, right? Due to its nature. It's put in the epidural space. So it has to be given by a consultant anesthetist, right? Or a trained anesthetist, right? And then it can be maintained in two different ways. Number one, it can be maintained with a syringe pump, which is a continuous amount of this mixture going into the woman, into the epidural space, and it blocks the pain going into the brain through the spinal cord. The second way is it can be given by boluses. So it can be connected to a syringe pump, or the bolus can be pushed in at regular intervals or when the woman complains of pain. So both these are acceptable ways in which you have. So a solution of usually bupivacaine, right, with fentanyl. Those are the two things that you remember. These are the two drugs that are used, bupivacaine, right? You don't need to know the doses. It's 0.0625 thing, right? Less than 0.1% normally, right? In combination with fentanyl, that is 1.112 milligrams. You don't need to really know the doses. Just remember, as MBBS students, fentanyl, which is also potent analgesic, right? And bupivacaine, which is something like lignocaine, right? So those are the two drugs in combination in low dose, which is made into a solution. And this solution is given in either boluses or it goes into a syringe pump. So different one. So sometimes 4 ml, 8 ml, 10 ml, 12 ml per minute, you know, that can be, and the syringe pump will push it in, or the attending midwife can, or the nurse can push it in as boluses, right? This, what is very important is because there can be that inadvertent injection of it into the different space, and that can cause problems like hypotension. And therefore, once an epidural is given, blood pressure must be monitored very, very, very carefully. And especially in the initial stages, where blood pressure must be measured every 5 minutes or so for about 20-30 minutes to make sure that everything is, and she needs to be monitored very carefully. The second thing that you have to understand is, once an epidural is put in, she loses her sensation of bladder filling. Okay, and therefore, if you forget to empty the bladder, she can sustain bladder damage due to the swelling of the bladder, where her sensation has gone off and she cannot feel that the bladder is full. And therefore, it is extremely important, if an epidural is going in, you need to catheterize the patient, right? And therefore, so remember that catheterization is very important for a patient if you are going for an epidural. Earlier, the epidurals used to be higher dose, and therefore she could not move her legs at all. So it's sort of almost like a spinal anesthesia. And what is important in epidural, if you want to go for an emergency cesarean section, and if there is enough time, then medication can be given through the epidural at a higher dose, and we can get enough analgesia for us to do a cesarean section with the same epidural. Or if rapid analgesia is required, we call it a spinal, combined spinal epidural, where a spinal is also given at the same time to quickly go for a rapid surgery if necessary, right? So those are the things that you need to remember. Usually the epidural will knock off almost 90% of the pain, right? Needs to be maintained by a professional, an anesthetist who has been trained, right? And it gives very, very, very good relief. And remember, epidurals do not prolong the first stage of labor, right? And epidurals do not increase the number of cesarean sections we do. That is evidence-based. However, epidurals can increase our chances of going for a instrumental delivery. What is the reason? Sorry. Right, okay. Right. So, so that concerns the error. So remember, what is evidence-based? Number one, what is evidence-based is it does not increase the duration of the first stage of labor, and it does not increase our chance of doing a emergency cesarean section. However, it does increase slightly the chances of having an instrumental delivery. Less the dose of the epidural, the less the chances of going for an instrumental delivery. What happens? Because she loses the sensation of wanting to push, and therefore that causes the pushing reflex to be less, and therefore sometimes we might need to do an instrumental delivery to get the baby out. So there is one disadvantage which might face. However, taking everything into consideration, the chances of pain relief that an epidural gives is very, very, very good, right? And therefore, it's very recommended. And if a proper epidural is given, right, it can give her a lot of relief during labor, right? So that is something that you have to remember. Right? Okay, now unfortunately I have to go, right? I have been called in for an emergency, so I need to go to see a patient in the labor room. So therefore we will have to terminate the session. Right, so what we'll do is we will continue this session. That's unfortunate for you and from you all and for me as well, right? So we will continue the session tomorrow, right? It will be a shorter session. So let me just summarize before I go, right? Right, I have a question. Can you summarize the key points told about epidural? Okay. Second, patients request for their preferred pain relief method in government sector. Yeah, in our labor rooms, epidurals are given, but sometimes the limiting factor are the epidural sets, which are expensive. But yes, we have an anesthetist allocated to our labor rooms, and epidurals can be given. Sometimes epidurals are limited to 1 or 2, sometimes per day, but yes, can be given, right? Okay, so let me just summarize what we are talking about. First of all, we discussed principally what labor means. First stage, second stage, and third stage. First stage is from sclerodilatation to 10 centimeters dilatation. Second is from full dilatation, that's 10, up to the delivery of the baby and the clamping of the cord. The third is the delivery of the placenta, okay? And then when the placenta is delivered, the third stage is over. Next is, we discussed that first stage consists of 2 phases, latent phase and the active phase. Latent phase is from 0 to 4 centimeters dilatation, and active phase is from the 4 centimeters to full dilatation, right? Next, we discussed as how to recognize the active phase from the latent phase and how long it can be. So it can stretch from 1 or 2 hours to 5-6 hours or 6-8 hours, but normally it will be around 4 to 5-6 hours depending on the patient. In multiparous women, it is quicker. In nulliparous or in the first baby, it may be a bit longer, right? As house obstetrics, remember, if women comes with no contractions, no evidence of labor, no pain, but she is leaking or an amniotic fluid is coming out, please, please, please do not do a vaginal examination, because then we'll be forced to put her in the labor room to start off labor. Please do a sterile speculum examination. There you can look at the cervical effacement, dilatation, color of the amniotic fluid, and make judgments. And then if you do that, we can basically wait for 24 hours for her to go into spontaneous labor. Spontaneous labor, remember, gives us many advantages. It is less painful. The labor is goes more smoothly, and the chance of delivering vaginally without a problem is higher than us forcing to do something, right? Then once we have achieved all that, then remember, she is put in the labor room, and then it is 4 centimeters onwards, which is the active phase. And in that, we discuss nutrition, right? We said that she can eat and drink, right? If there are no problems. Second, we discuss hydration, which normal should be 100 ml per hour, right? Different problems like pregnancy-induced hypertension, preeclampsia, we have to cut down on the fluids, but normally we need to keep them well hydrated. Why do we need to keep them well hydrated? Otherwise, dehydration will cause suppression of the uterine contractions. Number 2, how do you, clinically you can say the tongue and lips are dry, right? And in the urine, if you do a dipstick, she will have ketone body. So she's dehydrated, and therefore it will reduce the contractions. So please remember not to make sure that she's well hydrated, okay? And then the third we discussed about analgesia. Analgesia, remember 3 things, right? First thing is pharmacological or other measures like back massage, all that thing, and labor companion, right? But that might not be possible in Sri Lanka. The second thing is pharmacological. The first thing is pethidine and morphine, but we often use pethidine. I spoke about how it works, its dosage, what are the problems there which we face, right? And second, we spoke about how effective it was. Next, we spoke about the mix of gases, which is oxygen 50%, nitrous oxide 50%. To get that together, that is called Entonox as the trade name. There may be other trade names, but that is the commonest name. Which how we do how it acts, right? And it's a short-term inhalation analgesia because everything goes out with the breath. So she needs to inhale it fresh between contractions, but it can give breathlessness and feeling of lightheadedness, right? So therefore, it might not be effective during the latter stages, right? And the third, we discussed epidural analgesia and how effective it is. Of course, remember, I have told you during the first stage, it will not increase the duration of the first stage. It will not increase cesarean section, but what it might increase is the duration of the chance of going for an instrumental vaginal delivery, right? And I have spoken about the 2 drugs that are involved, bupivacaine and fentanyl in very, very low dosages. If you increase that, the chance of the motor functions getting suppressed is higher, and therefore it will be nearer to a spinal anesthesia. So therefore, these are now low dose epidurals. So basically, the motor functions are spared so they can walk about, right? What it also does is we give a bigger allowance for the duration of the second stage of labor. That is from full dilatation to delivery, right? So a primiparous woman on epidural, we will give 2 hours, 3 hours for her to deliver from full dilatation. A multiparous woman on an epidural, we will give 2 hours to deliver. While without an epidural, for a primiparous woman, we will allow about 2 hours. While without an epidural, for a multiparous, we will allow about 1 hour, right? For the second stage of delivery, right? Correct? With epidural, nulliparous, 3 hours. With epidural, multiparous, 2 hours. Without epidural, nulliparous, 2 hours. Without epidural, multiparous, 1 hour, right? So we give a bigger allowance because she doesn't feel the urge to push when she's on an epidural. Okay, right? So I need to go. I'm really sorry. So I'll continue the class tomorrow at the same time. Okay. Bye bye.